Okay, guys, good evening. Welcome to this FRCS teaching webinar. This is organized by Orthopaedic Academy and Ortho TV. My name is Firas Arnaout. I'll be the host this evening. The presenter is Siddharth Kamat. He is an orthopedic surgeon. He works in the UK in Rotherham Hospital. And since passing his FRCS exam, he's been very active in teaching with the Orthopaedic Academy. He's presented multiple times, and he's one of the faculty who teach us in the courses, and his presentations are always very well received. So we are very happy and pleased that he accepted the invitation to present tonight.
Thank you.
So we will just, the session today, I'm just going to explain how it will run. There will be a short lecture. It's very concise lecture and focused on what candidates need to know for the FRCS exam. Following that, there will be a question and answer session when we listen to your questions. If you have any questions, please write them on the chat box, or you can talk at the end of the session and directly ask your questions. After that, we will have a short MCQ session when you'll be tested. There'll have be 3 MCQ questions asked, and we'll ask you all to answer these questions. Following the MCQ, we will have the final session, which will not be recorded, and it is a Viva session. So we will you have a hot seat Viva question when you'll be asked by members of the faculty, a Viva questionnaire for the exam. So if you are interested to take part in the Viva, we please ask you to express your interest by either sending me a message or raise the hand symbol next to your name, so we know you're interested in taking part of the Viva session. This is very highly recommended. We understand what you need, and we understand the stress you're under, so we will look after you. But it's very highly recommended that you take part in the Viva session. If you miss any part of this presentation or anything goes a little bit too quickly for you, don't worry. It's recorded and it will be posted on the Orthopaedic Academy YouTube channel and Ortho TV as well. So yeah, here it is. I just wanted to remind you guys of our courses. So we do Orthopaedic Academy 3 courses. One is the case-based discussion course, which we only have 6 participants per course, and we spend all day with the participants going through 35 high-yield exam-specific questions. We test you, and we give you the right answer at the end of how each question should be answered. And this very, very focused day, all day. So if you're interested in taking part of this course, we have one the 30th of October, and we have only 1 place left on it. And then we have another course on the 11th of December. We also have our basic sciences course, and next course is on the 20th of November. All our courses are on Saturdays because we know you guys are very busy during the weeks with your work. And also we have our FRCS mock exam course, a very popular course. We have, it's basically just simulating the exam, how it goes. So we have a one on 23rd of October, 4th of December, and 22nd of January. So I would encourage each one of you, please, to visit our website, orthopaedicacademy.co.uk, join our Telegram group, follow us on Twitter and YouTube. And if you have any questions, please send us a message. So without further ado, I'll leave you with Siddharth.
Hello, everybody.
You could please share.
Today, topic of discussion is about bone and its metabolism. So let me share my screen. So bone metabolism is a topic for today. There's an emblem of orthopedics. I come from Goa, so I got the coconut tree there and the sea. So bone is a composite connective tissue having a rigid structure, having cells embedded in calcified matrix. So coming to back, we got cells there and we got matrix, which is further divided into two, organic and inorganic. What are the functions of the bone? Why the bone is there? There has been time when the animal kingdom lived without a skeleton. But bone comes with functions of posture, that is to maintenance of erect posture and posture of limbs, protection of internal organs, for example, visceral organs, the neural organs, propulsion by legs and propulsion by hands, hands to use and do the things and legs to walk or run, proprioception and production of red blood cells, white cells done by the bone marrow. So bone biomechanically is a very good structure and tailored to meet the demands. Most important function of bone is to really maintain posture, and that is the stiffness. So bone is biomechanically strong in compression. It's a bit weaker in tension. That is, if you pull out, it will just it's less stronger than compression, and weakest when you twist the bone, it fractures easily rather than when you put tension or compression. So you can see this is a long bone here, femur of a child. You can see the physial plates. Bone derives around 5 to 10% of cardiac output. So if you see the bone, we got epiphysis, metaphysis, and diaphysis. So as you all know, this is epiphysis, where there is a which is separated from metaphysis by the physial plate. There's a blood supply which comes to the epiphysis. In this context, it comes from the obturator artery, and there is a blood supply separately for diaphysis, which has basically two blood supply. One comes through the into the medulla called, and it's called nutrient artery, which divides into two branches, ascending and descending, and one is periosteal. The nutrient artery supplies most part of bone, that is 2/3 of the diameter. It is a it is a it has a lot of pressure, and the flow is from inside out, whereas periosteal is a low pressure system which in which the blood flows from outside in. So this is the schematic diagram. You will note that at some point in some bones and some joints, the epiphyseal blood vessel can cross the physeal plate, and it has got implications in the clinical practice. I'll come to that later. So what are the types of bone? Bones can be divided as per the shape, size, like long bones, long, short bones, flat bones, irregular bones. But if you see histologically, they can be histopathologically, it can be divided into basically three types. One is immature type, which you can see in fracticulars or some periosteal reactions due to tumors. There's a mature bone. Mature bone is divided again into two types. So this is a piece of mature bone, and you can see some areas there which is medullary, some areas which are cortical. So usually the cortical bone is a lamellar bone, Lamina has a definite lamina and lepid structure, whereas the cancellous bone in the medulla is trabecular bone. That means it has trabeculae running across in various directions. So to show you in more details, you can see this uh, two types of bone schematic. You got a trabecular bone up and a lamella bone down. Trabecular bone has got trabeculae of bone running in various directions, whereas in the lamella bone, you got lamellae of bone organized in a organized structure called osteon. I don't have a histology of the immature bone, but I can show you X-ray of a fracticalis which shows immature bone, which is poorly organized and has got not so much biomechanical strength as like a mature bone. So how does the bone develop? So bone development is a systematic process regulated by various genes. So they say that around 6 to 8 weeks, 4 to 8 weeks, basically, the limb bud appears. So the embryo throws off this limb bud, which got various zones. One, the brown area, which you can see, yellowish brown area, is the mesoderm, which is going, and it has got topping of apical ridge, and it has got a polarizing zone. So what does this basically do is these are regulated by genes. For example, proximal distal growth is modulated by Hox gene, anteroposterior by SHS gene, and dorsoventral by WNT gene. So total number of bones which we have is 206, and this is the way the limb bones are formed. So you got a limb bone which elongates and it takes ectoderm and mesoderm with it, which further differentiates into types of bones and shapes of bones. The limb bud for lower limb actually develops a week or two after the upper limb bud develops. So if you have a look at this diagram, you can see the primitive mesoderm having primitive mesodermal cells. And during the development of bone, some of them get transformed into pre-osteoblasts, which again organize themselves and get converted into osteoblasts, which throw off bone. And we have the membranous bone formation. Bone can also form another way. In this way, the mesoderm forms a cartilaginous analog with a small primary center of ossification, which later on gets vascularized. Still later on, we get a secondary center of ossification in epiphysis, and it gets vascularized. This goes into many stages, but I've just grossly mentioned the 3 stages. So you got a cartilage analog which gets converted into bone. The primary center of ossification, the ossification which starts before birth, with the exception of distal femur, whereas secondary centers of ossification comes after birth. So when you say when we know that endochondral ossification, and we got primary and secondary centers of ossification, how does bone further grow from the birth to or further? So for that, we have the physial plate or growth plate, which has got various zones. Like if you see growth plate, this is toward the epiphyseal side, whereas this is diaphyseal side. So if you see on the epiphyseal side, we got a artery which supplies some resting cells which are lying there. The resting cells soon proliferate, and because they proliferate so quickly that they sometimes do not completely separate, and they have a way appearance of getting stacked. As they further grow, they go into third zone, which is a zone of hypertrophy, in which there is a growth and the chondrocyte become bigger and bigger, and finally it ruptures and dies itself and releases all its minerals and matrix into the system, which further becomes bone. And we, on the metaphysical side, you can see the already formed bone, and there are arteries which form a hair loop, which actually increases the circulation there and achieves mineralization or ossification of mineralized matrix. So you will ask me how much percentage of growth occurs at each joint. So if you see upper limb, 40% of growth occurs at shoulder, whether elbow it is 20%, wrist is again 40%, hip proximal femur is just 12%, knee is 70%, ankle is 18%. So if you consider the lower limbs, nearly 1.5 centimeter of growth occurs per year at the knee, from the birth to skeletal maturity, which is around 12 to 14 years in girls and 14 to 16 years in boys. So coming back to the structure of a lamellar bone, we have Haversian system. The basic model or basic unit is called osteon. So if you see this diagram, you can see a cross section. You have some periosteum here having two layers. One is fibrous and another is cellular layer. Cellular layer is very important because it is important to have the breadth of the bone along with the length. So it's important. It does give some appositional growth. If you see the inside, you got a Haversian's canal, which is a central canal through which artery and vein and nerve flows. It is surrounded by a lamellae, which are held by osteocytes, and at end where the lamellae are there is cementing occurs through this phase. The basic unit of a lamellar bone, we got osteocytes layers arranged in circles, which causes mineralization of matrix. So what are the cells? I told you about the cells. We insert some tiny joints. There are some cells which are important. So if you see at the bone, this is a bone where you can have a cortex and medulla. The important cell to know is osteoblast, because a lot depends on this. This is a basically derived from radiculoendothelial cells. It's a multi-nucleated cells which lies in the crevices in the bone, and it has got a ruffled border through which the bone absorption occurs. All right. So whenever this cell is activated, it does two things. It releases enzymes which dissolves the matrix. I told you some time back that a matrix is having two components. One is organic and one is inorganic. So organic component is basically collagen 1 and some other proteins. This is degraded by an enzyme called cathepsin, which is a proteolytic enzyme. The second part is minerals. Minerals are in two forms. One is hydroxyapatite and second one is brucite. So the second enzyme released by osteoblast called carbonic anhydrase dissolves these minerals and then blood vessel flush them away. So this is a very important cell in bone turnover. The second cell which is there is called osteoblast. Osteoblast is derived from the mesoderm. It goes to the progenital cell and osteoblast. Osteoblasts are active cells. Why are they active? Is because they are secretory. And what do osteoblasts secrete? Osteoblasts secrete proteins. And the matrix and the protein, the main framework which forms the bone, is so it's secreted by osteoblast, and so osteoblast becomes a very important cell. It undergoes three phases. It either undergoes apoptosis and dies, or it gets converted into a lining cell, or it gets converted into the next cell, which is osteocyte. This is a fairly inactive cell. However, it has got a very important role in maintaining calcium phosphorus homeostasis. So this is the cell which actually mineralizes the inorganic matrix. Sorry, it basically mineralizes the matrix, the collagen matrix, which is secreted by osteoblast. So, as I said earlier, matrix is 70% of minerals, which gives which gives a compression strength to bones, and 30% organic, which gives the tensile strength, or which avoids or gives a strength against the pull on the bone. So when we see the organic component, we got collagen, which is a triple helical structure made up of alpha chains, and the crystalline structure made up of hydroxyapatite. So these two combine. So collagen molecules interlace with each other and create small pits in which this hydroxyapatite crystals sit, and that's what we call the bone matrix. So there are other proteins secreted by osteoblast which helps. It's got some regulatory role like osteopoietin, osteonectin, osteocalcin, and elastin. So bone is a constant turnover. It gets reabsorbed and deposited. This is a very important cycle. So consider this is a bit of bone which is having the liner cells, which are inactive osteoblast. After some time, the rankle stimulates osteoclast, and it eats some part of bone, and it creates a crater which is filled by the osteoblast, which forms bone and fill the crater, which in turn will get replaced by the calcified matrix, osseous matrix, with the help of osteocytes, which will deposit calcium and phosphate there. So what are the mechanics in the bone? I told you bone growth occurs, but how does it occur? What helps the bone growth? We got certain laws which help. So one is Wolff's law, which says that the bone aligns depending on how it is loaded. So this can be best in the femoral head and neck. You can see this bone has a tensile load on the lateral aspect and a compressive load on the medial aspect. So Wolff's law said that it will reorganize itself as to the load. And Utter-Markman further said that if you use a tensile load, both can get elongated. If you add compressive load, there'll be it will not be so much elongated. But because of compression, there's something else happens. Bone grows up trabeculae, which are thickened rods, which basically are condensations of osseous material, giving extra strength to withstand the compression. There's another effect which is also knowing. So whenever there's a structure bent into a C-shaped curve, there are changes in the electrical charges across. So on the convex side, there'll be positive charge, and on a concave side, there'll be a negative charge. So reverse, whenever there's a positive charge, it will bring the osteoclast, and whenever there's negative charge, will get osteoblast. So that's why the medial side is more dense than the lateral side. There are some chemicals which work on the bone, important of which is vitamin D. It's a fat-soluble corticosteroid which comes from diet or sunlight. So how does it come from diet? Diet, we eat diet which already has got active or inactive vitamin D, which gets accumulated in body. But what I'm going to show you is how does body make vitamin D. So we have a dehydrocholesterol in the skin, which get converted into cholecalciferol, a pre-vitamin D, which gets hydroxylized in the liver and then kidney to form the active vitamin D, which is also called calcitriol. So 25 hydroxy vitamin D is called calcidiol. So, and the active form is called calcitriol. And this is the one which is really important. The last step is regulated by parathyroid hormone, which helps and facilitates conversion of vitamin D to 25 hydroxy vitamin D to 125 hydroxy vitamin D. So if you see the vitamin D, it's basically steroids. So usually steroids have receptors which are inside the nucleus. So this is a vitamin D receptor in the nucleic acid, and we have vitamin D here. It goes all across there and activates the certain genes which cause synthesis of proteins like collagen, and it also synthesizes the enzymes like alkaline phosphatase, which helps the mineralization. Further, what it does, it also causes proliferation of cells, which causes the meiosis to occur more often, and we got many osteoclast, which help in mineralization. So what are the actions of vitamin D? Vitamin D is basically stabilizer of calcium and phosphate. So it does cause bone mineralization, but it also causes proliferation of osteoclast and helps in resorption if required. It absorbs calcium and phosphate from intestine and kidney. It inhibits the secretion of parathyroid hormone. It promotes immunity, hematopoiesis, and it's got some anti-neoplastic action. It also causes smooth muscle proliferation. So it's all healthy type of vitamin D. Coming to next slide. The other hormone, which is like calcium, bit less, is called calcitonin. It's a 32 amino acid polypeptide is secreted by peripheral cells in parathyroid. Basically, it works. It is osteoclast has got a receptor for calcitonin, which makes it inactive, and it blocks the absorption of bone done by osteoclast. So it's osteoblastic enzyme. Third chemical is parathyroid hormone secreted by chief cells having 84 amino acids, and basically it comes as a precursor and then it is broken down to active form. Basically, parathyroid causes absorption of calcium from bone by osteoclast, but it also helps absorption of calcium from intestine and kidneys. However, it causes inhibition of phosphate in absorption from the proximal tubule. So it has got a phosphorus loading effect. It is stimulated by reduced calcium, magnesium, and inhibited by vitamin D and increased calcium. So vitamin D, calcium, calcitonin are three main factors which cause the which maintains the bone homeostasis. So if you see the osteoclast, and the osteoblast sitting with the liner cells, and are not shown the osteocytes there. So when the parathyroid hormone is there, actually osteoblast is the one which has got a receptor for that. So when it goes and catches the receptor on osteoblast secretes rankle, which goes and sits on the receptor in the osteoclast. So when this receptor is activated, osteoclast become activated. Its ruffled vector get activated, and there's a bone resorption. Alternatively, when there's a plenty of calcitonin, there is secretion of osteoprotegerine, which catches the rankle and does not allow it to sit and activate the osteoclast. The rankle is got a full name, is complicated one, receptor activator of nuclear kappa ligand. So even if say rankle, it's enough. So this is how it happens. So the bone, in short, is a very dynamic structure, rich in blood supply, has got important function, has got a variation in structure, and has got a living lifestyle. Thank you.
Brilliant, Siddharth. I'd like to thank you very much for this very concise presentation, specific and exactly at the level of the FRCS exam. And I thank you for preparing all these media slides. I'm sure it's not easy. A lot of work behind all of this. So thank you very much. I think we've covered a lot, and I think most people would want to probably watch this a few times because, you know, basic sciences topics can be hard sometimes, but I think you've covered really a lot about bone metabolism there. Thank you very much, Siddharth. Appreciate that. I think we will move on now to the MCQ part.
Sharing it, and 3% have participated.
Fine.
So I think it's coming there.
Great. So we'll ask you all guys to answer the questions. I hope you all can see them. It's anonymized, so no one can identify you. Just have a go. It's very good practice, and there are specific for the exam MCQs. Once we'll give you 1 minute per question, and then we will go through the answers. Siddharth will go through the answers with you after that. So remind you guys while you're doing that, just after this MCQ part, we will go through, we'll have a Viva session. So Siddharth has prepared some Viva questions, and we currently have one candidate only, who is Muhammad Javed. If anyone else interested, please let me know. If no one else express interest, then we'll just have the one candidate. But if anyone else is interested, we have a maximum of 3 questions for the session. It's highly recommended to take part. It's good practice. I will give you feedback and we'll let you know. And it's a good learning for everyone.
All 18 have answered. So the question was, primary pathology of osteopetrosis lies in. So the answers were osteoblast 1, osteoclast 2, mesenchymal cells 3, collagen 4. So primary pathology in osteopetrosis is deficient osteoclast, which 63% have answered. So this question is correctly answered by 63%.
Okay, not bad.
Yeah, that's good.
Around what you expect in the exam, isn't it?
Yeah.
Yeah.
So another candidate has just joined. I think he has just answered now. So second question is, physis is intra-articular in all except one. The choices were wrist, elbow, ankle, and hip. So 53%, which is 11 out of 20. I think one more candidate has answered just now, said it's wrist, which is a correct answer. Whereas ankle, they said 30% cases not really correct answer. Question was bone mineral absorption at ruffled border occurs due to cathepsin, alkaline phosphatate, osteoprotegerin, or carbonic anhydrase. So 45%, which is 9 out of 20, has answered it correctly. That is carbonic anhydrase. So I'll end the poll and I'll see if I can share the results.
Much for explaining them, Siddharth. Yeah, that's
Okay.
great. Brilliant. Thank you very much. That's great. Wonderful.
Yeah.
Lovely. Okay, guys. Now we're gonna stop the recording, and we will move on to the next part of this teaching session, which is the Viva component of the exam. So, Siddharth, if you don't mind, please, can you get your first Viva question ready?
Yeah.